Welcome everyone. This forum is the Mental Health Forum, and we're going to be talking about using virtual reality for anxiety, depression, and chronic pain. And we wanted this forum to be, when we talked amongst ourselves, we want it to be as interactive as possible. So we want you walking out at the end of the session, not still having a question in your mind that hasn't been answered, or at least a promise that you're going to get an answer somewhere, either by email or in the post-conference material. So we want you to kind of start thinking about, like, in this field. I started, I'm Wagi Isaac. I'm the Vice Chairman of Psychiatry here at Cedars-Sinai. And I started with my trip with VR 25 years ago. I went to San Diego to a conference called Medicine Meets Virtual Reality, where I was just sharing with my panel colleagues about how every session I walked out of, my head was spinning because there were a new innovation, remote, robotic surgery, things that back then, 25 years ago, just like unheard of. And I think monitoring the field and how it evolved over the years has been amazing, because some of the devices are becoming now at the, within reach, similar to now, phones or big devices used to be like big problem to have them or to maintain them, and now we're each kind of like surrounded and wearing and carrying different devices, and it's becoming like that. This panel I think it's amazing how this panel put together, because each of them is kind of like a whole institution on their own. So I'm gonna ask them each to introduce themselves to you and share with you what they do. And then after that, we're gonna get started with questions and continue to build a good understanding of how virtual reality comes to service of mental health. So we'll start with you, Dr. Rizzo. Skip.
Okay, call me Skip, please. I'm a clinical psychologist by training, and I direct the medical virtual reality lab at USC's Institute for Creative Technologies. Also have faculty appointments in psychiatry and gerontology. And basically I got mixed up with this VR stuff back in the early to mid 90s when Brenda was coming on board as well. And at that point, for any of the older folks in the room, you might remember there was like a similar VR hype cycle in that era. The movie Lawnmower Man had come out. Public consciousness was captured by the whole concept of VR. And so in my clinical work, I got frustrated with the tools that were available in cognitive rehabilitation, mental health, with people with brain injuries and so forth. And so I just thought VR is the way to go, having not even tried it at that point. It was just the image of what VR was. And then when I finally tried it, after having written a paper about how VR was going to change neuropsychology, I almost wanted to retract the paper because the technology was really, really primitive. I mean, it was Stone Age. And, I think, as we see now, the vision was sound. The idea of using VR for all these wide range of clinical research, medical, wide-ranging applications, the vision was sound, and I think that's been borne out by where we're at today. And along the way, fits and starts. I mean, honestly, if I knew it was going to take this long, I might have chickened out and not left clinical work. But where we are today really is the technology's caught up with that vision, in terms of quality of the experiences we can create and the lower costs to do it. And the science has come along the way. Probably the largest scientific literature of any VR use case is in mental health, rehabilitation, medical applications. And so we're in a really great spot. And I know every 5 years or so, we would always say, in 5 years, it's going to be mainstream, you know? And it's like, well, I'm going to say it again, but it's going to be in the next 2 or 3 years. It's going to be mainstream. I mean, it's already mainstream in some places, but we're not going to have to do as hard of a sell job of the concept. Everybody will have an intuitive awareness of what VR is and how it may or may not add value in certain use cases in clinical care.
I'm Brenda Wiederhold. I'm a clinical psychologist also, and started back with Skip in the 90s using virtual reality. It was very antiquated and very cartoonish, but it worked, and that's because there was the proper content in it. And so I think it's exciting now that we have so many different options for virtual reality that we didn't have then, but also it's not all good. My patients come to me and they find things on the internet that sometimes do harm. So we were talking at lunch about, starting to curate that better as ethical, responsible people and putting that out there for the patients so they can find it instead of having to search for it when they're vulnerable, perhaps. I'm on the medical staff at Scripps in La Jolla. I have a for-profit clinic that does grants, research, design, develop, testing of virtual reality systems, ours and other people's. And we also see patients. My specialty is anxiety, stress, trauma, and pain. And I see a variety of other things because I'm on the staff at Scripps and I'm a clinical health psychologist. I also have a 501c3 that I founded, and we inform and educate policymakers, the general public, as well as professionals. So we want to get the word out that we can add the technology as a tool to augment the reality or to be a therapist extender. There aren't enough therapists right now. I'm also a visiting professor at the Catholic University in Milan, so I do a lot of work there and then consult for the European Commission. I think one of the exciting things about this conference is that, as Skip said, we had the dream, but the technology wasn't there. And so a lot of the conferences were sitting around a fireplace, having a drink, and saying, what if, what if, what if? And now the what ifs are gone. It's there. And so the pretty pixels aren't what makes it useful, but the quantity, and again, credit to Skip yesterday, he said Mark Zuckerberg, good, bad. He has really put it out there, and he's made it become mainstream, and it's a household word now. So I think this is exciting, and I think the field will take off this time. Thank you.
Hi, everyone. I'm Margot Paul. I'm a clinical psychology postdoctoral fellow at Stanford, and I do virtual reality research for people with major depressive disorder. I also work in the virtual reality and immersive technology clinic with Dr. Kim Bullock, seeing patients clinically using virtual reality, and I'm very excited to be here. Thank you.
Hi, everyone. I'm Omer Lirana. I'm co-director of virtual medicine at Cedars-Sinai, along with Brennan Spiegel. So until 3 years ago, I was at UCLA, where I worked for about a decade in the inpatient psychiatric unit. And I started doing some virtual reality work on my own after discovering it in 2016, when I put on a virtual reality and immediately just felt the immersion that it created, and that it was so different from other media. And I just started brainstorming, how can I use this technology to help my patients? And I did some research on my own island, and when Brennan Spiegel was writing his excellent VRX book, which hopefully everyone read, he came across my research, just emailed me, and we met up and asked me to come join him. And it's been really a journey ever since. So when people discovered that I can create these virtual environments on my own, I taught myself how to code at a very early age. I've been dragged away more from the clinical side and more into research and development side. So now most of my time is devoted to research and development of this virtual reality therapeutics. Very exciting field, and I'm so glad you all are joining us.
Great, thank you. So I'm gonna start the round of questions myself, just to kind of warm you up into asking the panel any questions you're coming across. One question I remember in the very early days, the very first application had to do, at least that I encountered, had to do with acrophobia, fear of heights. And it was a very circumscribed anxiety that is very clearly defined. It didn't have a lot of things to guess around it, and the app for it, for the virtual reality, had to do with graded exposure, the same way psychologists and therapists would do over time. And then I had, when I was at NYU, I had a patient who had fear of elevators. And so we, after some good rounds of in-depth psychotherapy to deal with other issues, unresolved grief and depression, we started to, every time she comes to see me at the clinic, to walk towards the elevator and just kind of like first grade exposure, just walk by, check out people coming in and out, touch the button, come inside the elevator car without it going anywhere. And I found myself trying to do this graded exposure. It was like, resistance of the patient, me kind of not knowing exactly what I'm doing, and kind of having that wish that what I saw for the acrophobia would be replicated, because when the fear is so well defined like that, it felt to me that you could kind of take it off. So my question to you is fast forward now, this is 2023. Can't believe even I say that. Where are we versus, applications to treat the phobias, animal phobia, elevator, flights, flying, fear of flying, acrophobia, and that would be my first question.
Well, certainly graphic fidelity has evolved, and diversity of the context that people have created to address a wide range of phobias. That's all there, although there is concerns that, you use one company's system, and it uses one headset. If you want to use somebody else's system, you got to use another system, another headset, or whatever. So that's a problem. But I think the phobia work was illuminating because I think it defined the first law of virtual reality, and that is that we can fool the brain. As primitive as the Larry Hodges, Barbara Rothbaum, Indiana Jones bridge was, or the glass elevator they built, and people, would look at it from the outside and say, oh, no, who's going to take that serious? But, and even patients, oh, I can do that. The frontal lobes are saying just a simulation. Oh, I'm going to be fine. But once they were in it, the limbic system lit up, the fear activation of being in that immersive environment in spite of the impoverished graphics. And that was where we really learned that, you maybe for face validity, you want to have things look more like the real world, but it's not, the graphic fidelity wasn't so essential to activate emotion. And I think that was the key take home from Brennan's opening talk was, he did a real deep dive into the emotional experience of people in VR. So nowadays, certainly, you've got different companies producing phobia applications and varying levels of fidelity and controllability. I mean, that's a big factor. And sometimes you find somebody with fear of elevators, so they can go in an elevator, but once that door closes, is it a claustrophobic reaction? Is it something that, depending on how many people are in that elevator, they're going to activate that fear? An empty elevator, they're good. And all of a sudden, you put people in these things, you start to learn more about the complexity of their condition. It's not just, the simple target of an elevator. It might be other things. And, so we can now build credible virtual humans that are props that can be put in that elevator or in any kind of a situation. Now we're moving towards, Freeman's work on the fear of heights. They have a little virtual human guide that walks you through the at-home kind of stuff. So you got support agents in that context. So, the problem might be, you can't base a field just on the phobia work. You know, I mean, I think there's a lot to be done in that area still, but it's, you know, there's just all these different barriers of different companies, different applications, how easy, how credible. We were talking at lunch about putting together a directory of where, you know, you punch in fear of heights, and all of a sudden, the 10 companies that are making those things, or research institutes, and, you know, a video of it, a list of features, a Yelp-like commentary section where clinicians can bellyache about how it didn't meet their needs or did, and the scientific literature. I think that's part of what we need in the field now, is to make it easy for people to know how to get this stuff. So, you know, phobia stuff, I think, jump-started the field, and it's evolved, but there's still a lot more to do with it. I mean, if you're going to really make it usable and available on a wide scale.
Great. Brenda.
Yeah, I agree with everything he said. No, it really was the low-hanging fruit to start with the phobia work, because it worked well, and it had intuitive sense, because before we were putting people onto freeways or in airplanes and doing that exposure in real time, it just wasn't controllable, it wasn't confidential, and it wasn't always safe. When I took people driving on the freeways in San Diego, sometimes they had a panic attack, and it was a little scary for me sitting in the other side of the car. It would probably be scary for the other people on the freeway too, and it was probably not too safe for the patient. So having the ability to do that in the clinic first, slowly at their individual pace, monitor their physiology in real time, have that objective metric, and use that to guide the therapy, and then translate that into the real world setting has been very powerful. It was really exciting when we moved past the phobias and said, hey, would this work with panic disorder? Would this work with agoraphobia? And kept on and on and on with the anxiety disorders, and finally post-traumatic stress disorder. My first post-traumatic stress disorder was doing it with motor vehicle accidents. Very, very, very powerful to be able to do that, have the patient process those emotions and those traumas in the virtual setting, in the clinic, having them sit and just hold the steering wheel and cry if that's all they needed to do that session. Because some of them have had very bad accidents. But then branching out into all the other things we've done, you know, for a while in the US, people didn't want to treat schizophrenia in virtual reality. They said, what if they have a further break from reality by using the schizophrenia? And I remember they started it in Korea, in Israel, and in Australia first. And they were having very good results, because you could take that schizophrenic episode and you could dial down the volume on it and make it was there. They knew it, though, was not real. And so they could start having, you know, reality schizophrenic, you know, activity. And I think, you know, Oxford VR, Daniel Freeman in the UK has done a lot with schizophrenia and has had really good results. National Health Services in UK has recognized his work as valid, which is a big deal. So I think we are starting to see a lot of companies having this. Some are good at validating their work, some are not so good. So I think the directory would be a really good step in the right direction.
Great. Marco.
Yes, thank you. Yeah, I agree with what has been said. And primarily for our clinic, something that we talk about is just the lack of the material that's out there in order to tailor it to the patient. There's a lot of different companies doing amazing things, and it's really just about finding the best thing out there and just having more of a uniform platform, because a lot of the companies currently all have their own headsets, and then that requires patients to purchase those headsets if they're interested. And so that is a barrier that we're facing in our clinic, and just a consideration as a clinician and for companies to have. But something that we were also discussing at lunch is just the idea that VR is used as an adjunct and to augment therapy based on what the patient is presenting with. So even in our VR clinic, we'll have patients come in and say, oh, I'm really interested in VR. And it's really great for a lot of things that, as Brenda was saying, like, for example, driving phobia, rather than driving with a clinician, and that could be dangerous, starting in VR, or a fear of flying and doing that in VR. So it's really great and provides the opportunities to do things that we couldn't as easily do or as safely do in the real world, and yet sometimes it's not going to fit the patient, at least not from what's out there now. So just considering and taking into account what the patient's bringing in, and rather than saying, okay, we're going to definitely use VR for this patient, thinking, what does the patient have, and is VR going to be helpful for this patient?
Great. Omer?
Yeah, so right now we're actually lucky that we only have two types of phone, iPhones and Android. But imagine a world where every time a company makes an app, they sell a completely different phone with that app. How successful would that model be? And that's where we find ourselves with virtual reality. Companies need to get together and decide that they're going to support one platform, whatever it is, web-based or Meta or Apple, or whatever it is. We can't just have one app for one device. We need, like Skip said, some kind of a menu, a directory of apps that you can just download to your device, whatever device you have. And I think that's really what we have to strive for if we want to make strides in making this field global.
Great. Let's see questions. Right, over there in the back.
My name's Tom Norris. I'm interested in what we as general public, not scientists.
We're going to get you a microphone.
Yeah, we're going to get you a microphone, and I think we're going to do kind of sharing is caring kind of thing. If we can pass the microphone to the next person asking a question. Thank you so much, Tom.
My name's Tom. I'm interested in what we as a general public can do to spread the word about VR. I speak at a lot of conventions, and when I talk about VR, I get a lot of quizzical looks. And, I attest to the effectiveness of VR, but the people that I work with in support groups, most of them have no idea what the VR program is. So what can we do to increase the awareness of VR and get the government, if necessary, involved so it's accepted? Thank you.
Well, first I want to say thank you, Tom. Nobody does more work to support VR than you do. So I greatly appreciate everything you've done. I don't know that it should be the public's responsibility. It should be us clinicians getting together with companies like Meta, Apple, and others, and bringing awareness to those companies that their app stores need to support some kind of a medical model. Right now, Meta has a policy that all medical apps automatically go to the app lab. And the app lab is where apps go to die, basically. I don't think they're not taking this technology seriously, and it's up to us to show them that there is a whole other market there, not just gaming, but this a medical metaverse that needs to be created. And hopefully they take that seriously in the near future, because we're going to need their help if we're going to make this widespread.
I agree. I agree with what you said. Yeah.
Just.
One tactic, and I used to do this right after the Samsung Gear VR headset came out, was whenever I'd do a talk, I'd bring a couple of them to the conference and hand it out to the people in the front row and say, take a look, pass it around. And it was amazing. I asked how many people have ever tried VR, and probably 20%. And so for some people, it was their first experience. Rather than trying to figure out from my convoluted talk, they could actually put the headset on and be swimming with dolphins. I think I had that on a continuous loop. And people pass it around now. With COVID, that kind of put the kibosh on passing around headsets. But you could maybe still do that. Give hand out wipes or whatever, and let people pass it around and get that experience. Because I think until you actually have the experience, that first time experience where you see the mouth open, that's when people get it, you know, and then you follow up in your presentation about the evidence, you know, get across that there's evidence here. This isn't just, you know, some harebrained scheme. So.
Yeah, just very quickly, Tom, we were talking last night, and I think your idea about writing the book would be excellent. I'd love to help you with that, and I'd love to provide you. I wrote a book under the nonprofit, and Skip was one of the chapters. I was one of the chapters, but it was the people doing VR at the time. But then there was a companion book that was called Virtual Healing, and it was the patient stories, and I think that sold the most copies. But I can send you those PDFs to hand out to your group and start spreading the word that way. I try under the nonprofit to spread the word, like go talk to the Mental Health Caucus in the U.S. Congress, things like that. So would love to be in contact with you and brainstorm on ways we can do that information education.
Next question, you have the microphone back there.
Yeah, this is a great panel because there's 2 psychiatrists, 2 psychologists, 2 VR pioneers, and 2 relatively new people. So I really appreciate this. And my name is Mike Arito. I'm an ER physician. I've been doing that for 30 years, but I've been involved in sort of the VR 3D space. I went to most of the MMVR meetings. I was involved more in the web and 3D, which is what I think the answer to you were bringing up is it should be WebXR that we should all go on because the web is for everyone. So anyway, the question I have though is I'm going to double click on what Dr. Rizzo was talking about in his talk about with the way the technology is going, and I won't use the C word, but I'll say generative language models are getting more sophisticated now. And so the reality is that we can start to make virtual smart avatars like SimSensei, you know, we can realize that in real life, scalable, that are smart, that can assess people using vocal biomarkers, using facial biomarkers, so that it knows exactly what the person is thinking, how they're feeling. And a lot of this research has been done already, and there's been papers on it, so, but more with the general language models, not yet. But we have a shortage of mental health professionals. It's not going to go away. There's like projected in 2030, there's going to be 24% a gap. So I want to know from every one of you, 2 psychiatrists, 3 psychologists, how you feel this field is going to evolve, because it's going to happen whether we like it or not, that we're going to be having these smart avatars are going to come. They're going to be essentially, we need to have this to fill in the gap. And I'm not saying to replace people altogether, right? So if you're seeing someone once a week, once every 2 weeks, maybe we can cut that down and have the smart avatar see them, 25% of the time, so that you are freed up to see more people. So I just want to get your opinion on that, because I think it's going to happen much quicker than we want. This thing with this open letter to OpenAI to slow down, forget it. They're not going to do it. So it's the same thing with this. I mean, I'm working with a company, and we're going to start looking into this too. We already have a vocal biomarker. We're going to start developing a smart avatar so that it can be like a coach. But then, we can start upping the ante here. And so I just want to hear what you all think about that.
Let's see who wants to tackle this first.
Yeah, that's a really great question, and something that is a relatively or very new person in the field I've considered as well. And personally, I think that it's great to have something to help people between sessions or even while they're waiting to see a provider. And doing the research that I'm doing for depression, even thinking of using virtual reality is a way for people to engage in positive activities even while they're waiting to see a provider, just because the end goal is to make people feel better. I am personally not worried that my job will be replaced by robots or AI, only because the research shows that the therapeutic alliance is the most important aspect of therapy, and that's the person-to-person alliance. And so while I do think that it's and welcome support in between sessions or before people are waiting for sessions. I think that it is very important, and especially seeing some patients that are more isolated or based on their presentation really do need that human connection and that in-person connection with another human being. So that is also something to consider, but I do think that it will depend on the patient and on, again, the patient's needs. I think in mental health, it is so individual, and it's hard to generalize and say, yes, this will work for everybody, because everybody brings something different and something unique, and everyone's struggles are different and unique. So really, it's about what works for the patient and what's in the patient's best interest.
Yeah, so I'm actually not so sure about the safety of our jobs anymore. I don't know if anybody in this room, I hope everyone tried to interact with GPT-4. And I'm not talking about the AI that came out, 4 months ago. I'm talking about GPT-4 that came out, 2 or 3 weeks ago. It is absolutely amazing and still in beta. And I've seen people develop countertransference to it. People use it as therapy already. When you combine that with virtual reality and have an avatar of the therapist, people can choose which therapist exactly they want, what their voice is going to be, and how they personally want the therapist to interact with them, what kind of therapy. I just don't know how well we can compete. Of course, for some people, they will need that human-to-human contact. But I think overall, this is very positive because there's a huge shortage of therapists. And most people in disadvantaged areas are unable to see a therapist. A lot of therapists are cash only, and insurance companies just don't compensate therapists enough for their work. This can be a solution, but we have to be very smart about how we do it. I'm sure many companies are already working on this solution, and I wouldn't be surprised if this starts happening within 1 year from now.
I think, the old saying, what you resist persists. And, it's just foolhardy to have this prohibition. We're not going to do anything in AI. That's just crazy. I mean, it's just not even feasible. Horses out of a barn. But I think that as a psychologist, I'm like looking at my watch waiting for APA, American Psychological Association, to maybe come up with a position paper or put together teams of experts to lay out some ethical, professional, and research guidelines so that we're all kind of on the same page. Let's kind of self-regulate how this stuff gets out there, or how it gets developed, or how we evaluate it, and what are the risks. You don't want to have a patient that, the same thing with online therapy. Some people go online and they think, oh, I'm going to do this online program and fix myself. And it might not be any validity to the program that they're doing, or it's not implemented in a way that leverages a therapeutic alliance with a real person. And they don't have a success experience. They, and then they don't, what's happened is you've given someone an opportunity to do something easy that doesn't work and prevents them from maybe doing something a little harder, but may have a better chance of working in in-person therapy. So, my toe in the water really is about obviously breaking down barriers to care, getting people facile in understanding a therapeutic process, build self-awareness, and maybe, it's going to grow to a point where people can help themselves. But we got to be real careful because we don't want to not deliver quality, ethical, professional care, with a shortcut, and have it lead to more problems. I believe it's going to be like you're saying, that there's going to be a time when this stuff is going to be really good, and then that'll be a fight we all can have. That'll be the most contentious issue in healthcare and mental health in the next 10 years, 5 years, maybe even. But to ignore it and to not try to set up guidelines. The National Academy of Science should have a working group and put together, what are the challenges, what are the ethics, what are the research guidelines, what are the big issues to tackle, all the guardrails, but all the things that inspire people to actually do the friggin' research to determine it rather than shooting from the hip and going from the gut. So it's going to happen.
Just a very quick comment. The publishing world has actually put out their definitions and their ethics on this and how they will deal with people that use ChatGPT for publishing. So I'm hoping that both APAs will do that soon, because I just worry about deep fakes. So patients not knowing who they're talking to. Are they talking to their therapist or somebody that's pretending to be their therapist? Or are they talking to a robot or a chatbot? So that's my only concern.
Yeah, I mean, I think these are great points. In the old days, I'm sure you guys remember this program called Eliza. And it was just kind of like resonating to you, what you say. It was like really pathetic. We're looking now at more sophisticated elements with inventions, which I think will prompt us to think through what is therapy, what is the purpose of it, how much of the role is the interpersonal piece, and how much of the role is to teach somebody self-reflection, even in the absence of that interpersonal connection. Dr. Jewel.
Thank you. It's been a pleasure, and it's great to see this panel. I've been working in VR and developing capabilities in medicine since 2014, which I believe was Second Life was something before they called Sansar. But I'm a space medicine physician scientist, and we train and we deploy analog astronaut missions to really austere, dangerous environments under ice, which stands for isolated, confined environments, including astronauts in space. And so we've been working and developing and testing these clinical trials, or these studies, and we actually noticed over the years that there was VR fatigue when the individuals are using the headsets, and depending on the type of headsets as well, of course, and then the placebo effect. So I want to ask each and every one of you, in your trials or with your patients, have you experienced this, and how did you overcome these effects?
Real quick, if you have a question, you can raise your hand. I'll pass you the microphone. Go ahead, Dr. Omar.
Yeah, so placebo is something that affects all of medicine, and when designing experiments, we have to be careful to control for it. In our studies, we have sham VR, so because we're worried that people, just because it's a virtual reality headset, it's new, it's novel, they're gonna get the effects. So we give people, the placebo arm a headset, but when they put it on, it's not an immersive environment. It's 2D video, with music. It could be nature scenes, but it's not an immersive environment. It's like sitting in a movie theater. And then we compare that placebo to the actual intervention, which is usually either skill-based VR or some kind of a 360 immersive VR. And it's a new science. We're still trying to get it right. We've had some experience that I would call a nocebo, because people just find it super boring. And if we tell people to put this headset on for 15 minutes, they just want to jump out of the study. So it's important to make the experiences nice, but if you make it too nice, maybe you get maybe it's actually a therapeutic response, not just a placebo. So it's probably not possible to get something completely neutral, but we do try to make the environments nice. And look, if you can just stare at pretty videos and listen to nice music for 15 minutes and get the same benefit as the VR, then what's the point of the VR? So we're not too afraid of making it too good. So that's the side I would err on.
Yeah, that's a really great question. For our study, in terms of VR fatigue and then also cyber sickness or simulator sickness, I have a talk with the participants about that beforehand and let them know that the research shows that in general, 10 minutes or less at a time decreases the risk of those things. And so I let people know that if you are experiencing VR fatigue, or I know some people, the headsets aren't really comfortable for them, and it starts to actually hurt, or they start to get nauseous, I encourage them to take it off and take a break, and then they can dive back in. And so in general, I found that that's effective, and most participants haven't experienced the fatigue because it is still very novel for the participants in the study, and they're just very excited to be in VR. But in general, for participants in the clinic, we do find that relatively shorter periods of time and then little breaks in between and then putting it back on helps decrease some of those effects.
Yeah, in the clinic, I normally use virtual reality for 20 minutes at a time. The frustrating part for me has been that I had about a 2% cyber sickness rate prior to the new headsets, and now I have about a 10% cyber sickness rate. So I don't get fatigue, but I get cyber sickness, sometimes SOPITE syndrome. But I found that you can for some of those people that still want to do the VR, I can use meclizine or an over-the-counter medication. It doesn't interfere with the clinical efficacy of the treatment. But I've not really seen the fatigue because I do the 20 minutes at a time.
Yeah, you just have to accept there's going to be a certain percent of the population that VR is not going to be for them. They're, just reality for however their nervous system's wired or their past experience. I mean, not a deal breaker. I mean, 20% of the population gets seasick, but the cruise lines are still thriving. So, and people sometimes will deal with the seasickness. And one thing with the VR stuff sometimes is you find people, after they've been in it, repeated short exposures, it's an easier go of it. But the short 20-minute, 30-minute maybe exposure is pretty good. One thing related to it, because you're mentioning about the placebo stuff, just, old war stories here with Hunter Hoffman, who's, the granddad of pain, distraction, and VR. In one of his very early studies, he wasn't even using Snow World. He was using Spider World. It was a spider phobia world as a pain distraction. But what the cool thing he showed, this is 2000, I think, was that one thing he wanted to test right away was not only immersing somebody while they're getting burn wound care, would it help, or physical therapy after a skin graft, but he wanted to see, is it just a novelty effect? Is it just that the person, wow, VR, and then it wouldn't endure? And he, his first series of studies, 2000, I think, showed with physical therapy after a skin graft, very painful but necessary process, that the effect endured up to, I think it was 7 sessions. They tracked it. So that was one of the first cases to say that in pain management, it wasn't just a novel thing of being in a VR headset and having that experience, but it continued to have that analgesic effect over time. So, just a little history there.
Thank you so much, and we have a lot more to talk about in pain. Let's take a question in the back, and if you have a question, you can raise your hand. I'll give you the microphone.
Hello, my name is Harley. I'm a novice to this experience, but I'm a PA. I work with a sports neurologist and pain medicine physician at Curl & Jobe, and I'm here to find out more about the VR experience. We're actually planning on looking into VR to incorporate that into our practice for our chronic pain patients. Obviously, this is apropos because you obviously are working with chronic pain patients, anxiety, depression. We have plenty of patients in those kind of sphere. We work with a lot of patients who suffer from concussion and the sequelae from concussion and post-concussion symptoms, prolonged symptoms there. So, when I look and I step out into the kind of exhibitor space, it's fantastic, right? So I'm like trying everything out, but I guess one of my questions is, in your expertise and experience, have you found that there is maybe one or two or any specific company that you've been working with that is that has provided you with ease of experience for patients, or kind of access for patients? I guess that's part one of the question. The other part, I guess, would be on the funding side. I'm not sure if it's just grants right now, if it's patients have to pay out of pocket for it, are we getting, is there reimbursement for these things? Unfortunately, Dr. Williams couldn't be here with me, but I'm sure he would probably have these similar questions as well.
Yeah,
Thank you so much. Yeah, all right. So this is the tricky question, especially that part one. Go ahead, Margot.
Yeah, so addressing part one, we were laughing up here because we were discussing this over lunch. And I was saying that, yes, in being here and looking at all the exhibitors, there's a lot of great things happening and companies doing really amazing things in the sphere of mental health and physical health as well. And yet, as a clinician in our clinic, we are struggling to find a program that really has most of our needs. And unfortunately, it seems like, at least in my personal experience, and I know we talk about this in the clinic as well, it seems that there's almost been a little bit of a regression in the mental health space in terms of the companies where virtual reality is concerned, just because of funding. And it is difficult for companies to really gain traction and to reach providers, because a lot of providers don't really feel comfortable using virtual reality, and so it is hard to gain that traction. And because of that, and because of difficulties with funding, it's something that I personally struggle with when I have a patient. It's so clear, and there have been so many papers that show how effective and how helpful virtual reality can be, and we've all talked about that. And yet it's finding those companies that are able to deliver what we need to give to our patients. I know, for example, with a lot of the work that I do in the clinic with virtual reality, it's important to be able to assign patients homework, to do exposures, for example, for phobias or for social anxiety, for homework, and very few companies offer that. And then, as we've talked about too, it's just a lot of companies have a different headset, and patients need to be able to invest in those headsets. So it is really difficult right now, and I would love to hear if anyone has ideas of companies that do have what we're looking for as clinicians, but it's something that we've struggled with in my clinic.
All right, well, I'm not going to mention specific companies, because if I mention one, 30 others will be angry at me because of my position. But I'm going to say that there are great companies out there. It is hard to access because, like I mentioned, they all live on different headsets. There's not a centralized place where you can just access all the great programs. And of course, there's not just one program for everything. Different patients, different elements require a different therapeutic approach. So this is a very new field, and it's still evolving. We'll see which companies survive this phase of low funding and reach the next stage. But we at Cedars-Sinai, we develop also internal software because of necessity, because for the kind of stuff that we want to do, we can't find software. We can't find anyone who's doing that. So we are making the software ourselves, and hopefully we can get to the point where it's validated, and then we can share it with the world.
Yeah, I'll just address the insurance reimbursement. Right now, one of the problems with getting clinicians to really want to come on board with this is you get paid the same amount if you have 2 chairs in your room and no equipment, and do talk therapy, or if you have biofeedback in virtual reality and do a empirically validated thing like CBT. So until the insurance providers change and get better coding systems so that they're really only reimbursing for empirically validated things, it's going to be difficult for some people to agree to pay the expense, because even me, I've been doing this since 1996. I need tech support because I don't have time to charge the head mounts, to clean the equipment, to do the updates, et cetera, et cetera, et cetera, and still see my patients. So I need that extra help. I am very proud Applied VR now has a DME code. So they've been given a DME code. So I see things starting to change, but we still need it to go a little further. Skip has done a lot with the VA system. They're starting to reimburse for a lot of this, and I think we'll see that trickle down to other, private payers. So I think this is good. One final thing from me, and then I know Skip has a lot to say on this. I showed a slide in the late 90s saying I wanted a universal platform. I still don't have a universal platform. So I have a clinic with 10 different systems in it, and I use the one depending on what the patient needs, but it would be so nice not to have all that space just for extra systems.
Just on the funding thing with writing grants, just real quick, because that's the area that, in academia I've been involved in a lot. And it's a real challenge because, you have an innovative idea and you apply to NIH, and it's like, well, sometimes they don't realize that, there's development cost for a system, as well as the money to run a clinical trial, which is crazy, and they don't pay a heck of a lot in these grants to do this kind of stuff, to build something from scratch. So NIH is difficult. The military is actually a good source. The CDMRP proposals that calls for proposals, they often have idea awards that give you some development money. The VA has been jumping on this quite a bit, designing things that you're going to make veteran-centric, but if you design from a process where you're just delivering a core process that you change up some of the content, and now it's a civilian app. We did this with a military sexual trauma exposure therapy system that turned out we had to build a lot of civilian content in that app, because most sexual trauma in the military wasn't happening in trenches of Afghanistan. It was happening around U.S. bases, stateside. So we got a little double dip in there because we got the Army money to do the military version, but it included a lot of civilian content so that you could do things, on a wider scale. And that's always something to look at when you think about, don't think of Army money as like, oh, it's just, it's Army and it's veterans. If you think about it, you can use that funding, which is oftentimes substantial, if you're with you get the right hit. And DARPA stuff, it's a little different, but you can build things that are going to have a wider range of application that way.
All right. Before we move to the next question, we were talking, and I think I'm learning from our panelists that, when you're looking for an app, you just download the app. It's going to be either Android or Apple. It's very easy, OS or Android. But in the virtual reality world, what I'm learning is that every time there's a new app, they develop, attached to it, a new hardware. So you can't just download this app into the existing headset that you have. Many of the new creativity in the area is also coming with new hardware. And that's back to Brenda's point about needing a uniform platform, because that's where people then can focus on developing the apps and the applications for the same, or one or two or three, let's say, platforms. That would make it easy. Okay, we have a question.
Okay, thank you. My name is Eric Jutten. I'm from the Simulation Crew. It's a company, VR company based in the Netherlands. I have a question for all five of you, and that is the topic is using XR for anxiety and depression, for instance. But what I would like to know is what kind of XR application doesn't exist yet, and where are you dreaming of in that field?
I would say one of my main things is there's, probably 30 fear of flying worlds and 30 or 40 heights worlds, et cetera, but there's not a lot of other phobias or a lot of other disorders out there. So my goal would be to get things that you can have a basic world, but make it so that a therapist, and I think we can do that with some of this new software, make it where a therapist can change some of the things on the fly. Or for instance, in the old days, we had software where I could put a person in turbulence and do it over and over and over again, or I could flip things around. And now some of the software, it's like you have to go through the whole flight before you can start over. It's like, this is backwards. This is not the way it should be. I also have people that come in with fear of, dogs or snakes, things like that. There's very basic worlds for that, and they're not very good. I mean, I've tried to see patients, and I've had to take them to pet stores in the end because the virtual reality just isn't working for that. So I think things need to have more interaction, and maybe like what we've always done, I know Skip's done it too, we've had the patients involved in making the worlds. So you have the computer graphic artist, you have the computer scientist, you have the therapist, the subject matter expert, and you have that end user, that patient involved, and you do an iteration and they tell you what's wrong and keep going from there. So have the team work together. Did you want to say something, Skip?
Is really about what we want in the future. Is that the?
Yeah, I mean, that's, I want it all available online.
Yeah,
The metaverse stuff
right.
without a head mount.
Right.
Sorry about, I got so caught up in.
No. The areas that I'm focused on are trying to expand out the trauma-focused work, and not just with direct exposure therapy, but developing applications where you can apply other clinical approaches, whether it's EMDR or some of the cognitive behavioral things that are out there, but for a wider population. And one of those populations I'm particularly interested in is with children that have had adverse childhood experiences. I mentioned this at the tail of my talk, but I think it deserves more attention because we are finding out that, the number, you give a simple 10-item checklist of incidences of abuse, neglect, or dysfunctional household, and have people fill them out. If they fill it out honestly, there's a direct correlation with cardiovascular problems, diabetes, all these other medical conditions, depression, anxiety, functional problems, juvenile delinquency, failure to complete high school, substance use. I mean, it's just a direct relationship. And so I think, this prohibition about using VR with people under 13 is maybe limiting some of the things we can do. I'm not saying put a 6-year-old in a hardcore exposure therapy app, but there are ways that you can engage children in things that help them to make sense of their experiences that may be relevant to trauma. And one that I always like to promote is Jessica Stone's virtual sand tray. And here it's not exposure, it's kind of exposure, but what it is basically a child, it's jumping off from the play therapy approach where it's basically a sandbox and a bunch of physical objects that you have children put and play and describe the world that they create. Kids that can't really put it into words what they went through, but they represent it. And she's developed a virtual version of it, so you don't have to set up the physical sand tray. You don't have to buy all the little miniatures and all that. You get an iPad, you pick a world, you pick the sky dome, you have birds flying over, you have the sun, you've got 6,000 different objects that can be brought in there. And the kid can build it and co-construct it with, the therapist, patient, whatever, the parent, whatever. But then kid can put on a headset and walk around. And the therapist can also put on a headset. And it's not like the kid is telling their story, because you want them to be able to tell their story. But it's not like the kid's telling their story to an adult who's sitting there taking notes. It's like the kid is immersed in this world and pointing out, the elements that they've created. And the therapist can say, oh, well, why did you pick that one? Or what about this? Or, whatever. And they're both immersed, but there's not that confrontive element. To me, that's genius. And I really think that we need to pay more attention. I mean, certainly with the pain stuff at Children's Hospital, Jeff Gold, he's doing things with kids that have fears of IVs, needle sticks, other pain conditions. I don't know at Cedars, do you do anything with kids much?
We do. We in the pediatric ICU, we use environments especially made for kids, and mini games to distract them. Yeah, right. To distract them from anxieties and pain, and that's something that we only recently started doing, but it's expanding, and so far it's going very well actually. I think that was, first of all, a very great question. And my answer is that it's really only limited by our imagination. And I'll tell you what we've been doing is we've been looking at what in the real world that's non-pharmacological has been helpful for anxiety, depression, chronic pain, and others. And then how can we take those and put that in the VR? Because we know, for example, that cognitive behavioral therapy works. The problem is that even in Los Angeles, even for me, when I try to find a CBT therapist for a patient, it's almost impossible. 4-month wait list. $400 an hour, just the patient can pay that. Trying to go through the insurance company. And this is in Los Angeles. I can only imagine what's happening in rural America. So we need to find ways to take those therapies that we know work and put them in the VR. And I can list many things like that. There's nutrition, exercise, really the list goes on. And that's just translating real world therapies to VR. I'm really curious to see what we can do in VR that we can't even imagine right now. We're just waiting for the right genius to come up with those treatments that were just not unavailable before. I'm sure they exist. So if anybody has ideas, it's something to think about.
Thank you, Omar. So go ahead, Mark.
Oh, just really quickly, great question. And I think similar to what Brenda said, just having the ability to modify the virtual worlds to the patient, because it's rare that you get a patient that has just like a very general phobia of like a general bridge, for example. It's a lot of times it's specific environments, specific situations, so just really being able to modify it to the patient, and also having the ability to assign homework to the patient so that you're not just doing it in clinic.
Great, thank you. Tom, you had a question?
Can you hear me? Yeah, there we go. Actually, 2 questions based on being a consumer. One is, how do we push for a development of a pharmacological, for whatever the right word is, list of approved VR programs so people know what has met the standard, if there is a standard of care. And the second is, how do we push for a standard of care with VR? I mean, I see a lot of programs out there. Who is working toward developing the rules? Does that make sense?
I know Skip has worked on a panel with Brennan and some other people on developing rules. I've also worked on a panel in Europe with the EU group about developing kind of certain rules about how trials will be held, so clinical trials, randomized trials, as well as what elements the virtual worlds need to have in them, and if they're therapist-led or consumer-led, and if they have that capability. Like with PTSD, it's a really difficult one to look at, just putting that out there and having it led by a person, because you don't want to re-traumatize a consumer, especially my guys that come in, not to stereotype, but But the guys, they're like, okay, put me in the worst level there is. And it's like, no, look at your heart rate. Not going to do that yet. So, you know, putting some of those things out, I think we're moving towards that. But it's been really difficult to get groups. The NHS has done a great job in the UK. But to get groups in the EU and the US to do that, to declare that we have to have those standards, they've not really been as easy to do that. They've done the FDA breakthrough devices, and that's about as far as they've kind of come. Yes?
Do you have any recommendations for how we can push this? I mean, I'm a firm believer in VR, and because it works for me.
You know,
But like I said, who knows? Nobody knows.
I will say one thing, and then I'll pass it because Skip's got some great ideas too. I know when PTSD came along for virtual reality, we were asked to go testify before the military subcommittee in the U.S. Congress. And I think, you know, unfortunately, it takes some face time on the Hill to get some of this pushed through, because I don't think American Psychological or American Psychiatric has really taken the lead on doing that yet. And you know, maybe American Medical Association will, but I think almost it goes to the congressional level in some ways. You might disagree, Skip. No.
I agree with that. I'm going to put a good friend on the spot here in a minute. But, you know, how do we advance it? Well, is it going to be the market forces that advance it? You know, certainly 10 years ago, you would have seen 4 booths out there, and now there's all this product. And maybe that's going to draw the attention, because now it's not just stuff that sneaks out of the lab. It's like these are consumer products, basically. So maybe that's going to be one of the big drivers. But there's somebody in here I want to put the arm on that might have, because he's worked in this area for a while, and he might have a better view on what it's going to take. Brendan Hale. I think you might have a couple of comments just about this. I don't know if you want to put your neck on a chopping block here, or what's it going to take?
Yeah, get your microphone.
Brendan's a good buddy, works with Penumbra, and we're working together on a couple of VA projects, and really respect his view.
Thanks, Skip. I appreciate it. And kudos. I do have to mention that Brenda and I had worked together for quite some time, and much through the pandemic, and so thanks to Brennan for putting on the vMed conference, because it's the first time I've met Brenda in person, which after all those years on Zoom, it's like, hey, wow. But anyway, I think Skip is right. I think there's essentially realizing that there's different value drivers for each stakeholder group within the healthcare ecosystem, and understanding how we're going to leverage the data that comes off of the hardware, the data that comes from the software that is based on a mechanism of action that we're capturing, and then taking that and really driving home what the value is to each of the stakeholders, because each of the stakeholder groups has a very different value metric for what they're assessing. And so providers have one value metric that is clinical evidence and clinical effectiveness or efficacy. Then there's market forces, and what's the size of the opportunity, what's the number of people that have that condition, what's the reimbursement or what's the payment for it. Then you also have business distribution questions and the product questions, and there's essentially what I would categorize as there's 4 different verticals that you have to identify when you're building a product. And all of these great companies and all of this great work, they've all really focused on the left-hand side of what I would put in a spreadsheet, and they've focused on the clinical, but there's market, there's business, and there's product, and we have to think about all 4 of those to really leverage the development of these and be successful. So, anyways.
Thank you. All right, we have a question Go ahead.
Yeah, my name's Claudia Haskell. This is a in the weeds kind of a question. Skip, I noticed in your presentation you had Converse Sage as Converse Sage was one of the, and I've been following your work with Converse Self from way back. I'm imagining that's an iteration perhaps of the same concept of the patient becomes the clinician. Right, the embodiment experience of becoming the source of information for your next step as a client by producing the felt experience of being the wise one, the wise person. So I saw it a little bit in your presentation. I'm just wondering if that component is still in the works or if it's being compared against avatar helpers and coaches. Am I making sense?
Yeah, I'm not sure if I'm getting, I might have missed part of the question, but are you saying that, maybe ask it again.
Remember when you did the presentation a few years ago and you had the combat vet
Yeah.
who was going to ask for help and when they became the answer, meaning they were the clinician, they were the psychologist giving them the answer for their question, that it had replicated as good effect as having a clinical session. That was what the research came out of Spain saying. And so I'm just wondering if there's any testing going on with that against AI or avatars or helpers.
You know, that sounds more like the kind of stuff now that's being involved by Mel Slater,
Yeah.
who's going to be presenting next, which would be a great talk, by the way, not to be missed. And, you know, I think that this is sort of an emerging area of embodying people in different roles. We've seen it with empathy building, where people are in the role of somebody with a disability, or growing up black in America, or becoming homeless. Jeremy Bailenson, some of his work, which is really pretty good. You know, what Mel's doing, I don't want to steal his thunder because he's going to present on it. I think it's really important, and it also ties in with your work with depression, because in depression, that is like the dark continent. It's one of the most important clinical conditions to be addressing, but you know, there hasn't been as much work as with the anxiety or with PTSD or anything. But I don't know if you're familiar with Chris Bruin's work in the UK, where he did this embodiment thing where the rationale was that a lot of times people with depression have low levels of self-compassion. And they might be compassionate to other people, but not so much for themselves. So they brought people in, and they put them in a VR world where they said, all right, we'll give you some tips on how to be compassionate, and you're going to go in this world, and I want you to be compassionate to the other person in this world. And what it was a kid, a child in distress, and a person is in there, you know, wearing a headset, you know, talking, doing all the normal things. It's, you know, it's not forever, you know, whatever the tactics were. And then they flip the switch, and that person now is in that position of the child, and they're seeing a virtual version of themselves that had been recorded, and the body movements and the voice, and they're getting compassion delivered by themselves, you know. And the idea, I think, is that embodiment in that vulnerable role, but also hearing your own voice and your own embodied actor, character, whatever, representing it, that it's going to maybe stick a little more. I mean, you could say, well, do you record affirmative statements on a tape recorder and play it to yourself over and over? But I think that embodiment in that context might be a factor. In a small study, I think they've done more, but last study I read was 15, 20 people, and they got some good clinical benefits, but still preliminary. And what Mel, I think, is going to talk about today is some of his work, you know, talking to Freud, or or you're playing the role of Freud, asking yourself questions and flipping things around. It's something you can't do without VR, you know. So I think this is an important area. You want to talk about the depression? What do you think about that? Is that self-compassion thing? Is that exciting?
Yeah, so it's a little bit different than what I'm doing, but I do think that it is, yeah, I think it's a great application of VR, and I am familiar with the work that is being done. As Skip said, it's sort of like embodying the talk to Freud, and I think you said like Converself, which, yeah, is work being done where you can just switch and become the therapist and answer your own question. And as Skip said, a lot of, it's rare to find that research is being done with depression as a primary outcome measure. And I do think that is work that does need to be done in terms of increasing self-compassion, and with individuals with depression, having that ability to ask a question and then embody a therapist, and then see your own avatar ask the question and then answer yourself. I think that is definitely research that needs to be done.
Wonderful. And, this reminds me of the corrective emotional experience. When you think about that you're doing that with a therapist, maybe someone that you have a strong therapeutic alliance with, but this seems to me a little bit more intense, like, especially when you're unexpecting that this switch is going to flip. Because many people say, oh, I can't do that. This is not for me. I feel for others, but I can't forgive myself for X, Y, and Z. All right, next question. And that will be actually our last question, because we'll wrap it up a little bit after.
Hello, my name is Mariana, and I'm a technologist, and very curious about one thing I keep hearing, which is different levels of realism in these virtual worlds. And I'm curious, from your clinical experience, what is it that technologists should think about? We heard the chatbots can produce perfect interaction. There is a separate part of the generative AI, which is about images and visual and very realistic, made up fakes. What is it that works really for you? How would you use it? Where would you plug it in, or in what ways to help your practice?
That's a really great question, and I can speak just briefly about that. So research shows that as long as you can pretty easily trick the brain, and as long as there's you can sort of suspend your disbelief, and even in a world that's animated, if you have people blinking and just moving a little bit so that you trick the brain and it doesn't seem like very artificial, research shows that is effective. I've also had participants, just in terms of qualitative research, just tell me that they would rather be in more immersive worlds that were even game-like compared to more realistic worlds that didn't have as much interactive abilities. And so that's something interesting, and something that I'm looking at now compared to the 360-degree videos, how being in like a more immersive, but that's more game-like experience, how that impacts people's moods, and how that helps people's symptoms.
Omer.
So we're looking at how we can use these technologies to improve people's interpersonal issues. A lot of people have unaddressed interpersonal issues. Of course, they would be best served by going to a therapist, but many of them do not. If we can get it into those people's hands and improve their I think it could really revolutionize how we treat interpersonal issues. You have an avatar that you can practice in a safe setting, interacting with different scenarios. And this can be great for people anywhere from autism, but also just people who have many other interpersonal issues. So it's a very promising field that we're taking a serious look at.
Great. We're going to take one last question.
Hi, my name is Janar. So I have a background as a neuronurse working at UCLA Health. And just being at this conference, it's been really inspiring to see all of the different clinical use cases for VR being used for patients. And so I'll make the question pretty quick. Being a nurse, I'd love to know any thoughts or recommendations that you guys would have on tapping into the nursing workforce and helping deliver different VR treatments or interventions to patients at bedside.
Okay.
Are you talking about within the mental health space specifically, or?
Yeah, at really any space.
For nursing, so virtual reality for nursing.
Or for nurses to be
For-
able to,
To deliver the treatment? Yeah.
Do you want to speak to that? Because there's a psychiatrist.
So I just want to make sure I have the question correct. So the question is, nurses administering the VR or using the virtual reality themselves? Yeah. Yeah. So yeah, so using it for themselves. Of course, for burnout, I think that would be great. But for administering to the patients, right now, because it's so fragmented and there are so many different applications for different people, the nurses would have to be trained for that. And I've seen a lot of resistance from nurses to do that. I think it's best to have someone in the hospital designated, and that's what we're doing, to administer the VR. So the nurses call for a consult. Either the primary team or the nurses can call our team, and then we send people to administer the VR. And then we can choose which VR applications to use. We can educate the patient about how to use the VR software. We know how to clean the devices, things like that. In my experience, nurses have been resistant to learn how to do themselves. Also, then they have to remember to pick up the headset. They have to, nurses are already super busy, especially now post-COVID. I don't think they want to add another job to their work. We try to make it as easy as possible for the nurses and really respect their workload. And they actually love the work that we're doing because it actually does decrease their workload. The patients call them less. They request less pain medications, less anxiety medications. We can leave the virtual reality headset with the patient. And our team checks up on the patient. So what we found is that approach works much better.
Only specialization in healthcare, the VR guy.
Yeah, I mean, I will say, I think Cedars has done it in a really good way that other people are starting to follow, which is the virtualist. Because I think I've found when I've tried to integrate it into other healthcare systems that you almost need a dedicated person to do the virtual reality. So nurses should be trained on what the person is doing to their patients, but I think you need a separate person to do that.
Great. So let me make a bit of an attempt to kind of like add a lot of, points that we brought up today together. The one issue that stands up the most is the issue of figuring out where virtual reality is going to fit in the algorithm or in the approach to treat patients with depression, pain, or anxiety. So you think always therapy, pharmacotherapy, or psychotherapy, and the role of virtual reality here is coming up, but there's not a lot of standardization by professional associations or even by systematic reviews to figure out how and where this is now the time to bring virtual reality. The other issue that I heard also, so I want you to comment if I'm like offline. But other issue I heard is the issue of having a standardized platform where inventors and people creating products for virtual reality can actually run with it, knowing that the platform will absorb it. And much easier for clinicians to have 2 or 3 platforms to work with, 2 or 3 hardwares, if you will, to work with while the software is expanding. Same way we're dealing with our phones and so forth. Also, we discussed at lunch, this whole idea about how in the old days to load up a software, you needed to bring it on a disk or on a floppy drive. And nowadays, all you have to do is is just download it, and it downloads, wirelessly. And why is virtual reality products are still carry that old kind of cumbersome buying a new piece of hardware with a software that is just built in. So I think these are things that need to be developed. The third thing I heard also was very important is to develop this directory, this almost website that is all encompassing of all products invented in virtual reality, so that you can use a simple search engine. Let's say I have a patient with fear of flying. Now I should be able to plug that in and see all the products that are in that space. And then that leads me to their pricing, to their consumer rating, to clinician ratings, and also to research articles. So that's another one. And then we heard about the need for reimbursement for these services. And we also heard about the need for comparative effectiveness. As a clinician on the front line, I want to know what product should I use, and what is really the evidence for it that it's going to help my patient. The beauty of comparative effectiveness research is that it doesn't only show which product is better or which medication is better or which therapy is better, but more importantly, which is better for whom through subgroup analyses and heterogeneity of evidence analyses. That's where the money is. That's really where the field is going to go to more of a personalized mental health approach versus one size fits all. We have almost a minute left, so I want to give you a chance, any of you, if you want to have the final word, I would be more than happy.
All right, real quick, 47 seconds left. Oh, no, I'm stage fright. Just keep on rocking. The vision is sound. Come on, anybody who works in this field, you wake up every morning, and you're not like saying, oh, shit, I got to go to work. You're like, oh, man, I can't wait to get in there and bang this stuff out. So I hope you have that experience, because that's what this field inspires, I think.
Yeah, I think it was exciting to be on the bleeding edge in the 90s. I think it's very exciting now, and I hope Skip and I are still alive when it finally takes off.
Yeah, as someone new to the field, I'm really happy to be here, and I'm in awe just seeing all the expos and trying all the new things that companies are coming up with, and I'm just excited to see where it ends up.
Yeah, the future is exciting, and I'm actually giving the closing talks in a little bit, so I'm going to save my comments for that. Thank you.
Thank you so much for being here.